Good afternoon. It's great to welcome all of you. So I'm Victor Zhao, the president of the National Academy of Medicine. It's my great pleasure to welcome all of you. This is a very special session because for several years we've been working on this really important issue of clinician well-being and now called the health workforce well-being. And the last year, we've been working on the national plan. And what we want today is to really go over with you the national plan, get your input as we move forward in finalizing this plan, which you'll hear is going to be the roadmap, if you will, for collective action for the nation to address the issue of burnout and clinician shortages. So if I can have the first slide, please. So what you see here is what we've done. In other words, we are a collaborative that came together in 2017. This is before COVID. But already at the time, burnout, depression, distress was becoming a really significant issue. So with the participation of 60 to 70 core members, which are made of organizations like AAMC, ACGME, American Hospital Association, you name it, and 215 network organizations of hospitals and others who move forward with this collaborative, which has really rolled up our sleeve and done a lot of work. As you can see here, the aim of this collaborative is to increase the visibility of burnout, depression, moral injury, and suicide. And as I mentioned, we have a network organization, 150 statements committed from these organizations say they can do something about this, numerous publications, journals, magazines, and importantly, we undertook an initiative called Breaking the Culture of Silence to allow people who feel distressed, who feel burnout, to be able to speak up without stigma. And so we've done it through meetings, art shows, and public discourse. Second issue, of course, so important is to understand what's causing, what are the root causes of the healthcare workforce, distress, burnout, etc. And we create a conceptual model to understand the external and internal factors. And then we have papers that talk about what are the drivers of burnout, what interventions do we need to do so, what are the best practices, and what are the research gaps. And we created a knowledge hub where there's a single place to go to where you can get all that information, learning. In fact, we're about 1,000 connections, if you will, citations to look at this issue. Of course, importantly is to say, what are we going to do about this? So we've been working very hard to look at solutions, evidence-based and multidisciplinary solutions. We engaged CMS to say, let's look at modification of EMM code and documentation guidelines. And they have responded, and things are better, but not perfect. We've engaged the Federation of State Medical Boards and now other licensing boards, nursing, dentistry, etc., to look at guidelines for disclosure for physical and mental conditions. And of course, we work hard with the EHR vendors. Still a lot of work to be done to reduce the burden and to make it more user-friendly. I think at the end of the day, we are laying the foundation for long-term change. And we recognize the long-term change includes culture change, system level change. So first we do case studies to look at best practices to give guidance to organization, but we also have champion chief wellness officer, which is now in fact being adopted in many organizations, integrating the well-being into the culture of health professionals education. And of course, many organizations like yourself are measuring well-being, burnout, and plan. Next slide. So the whole idea today is the recognition that despite all this work, we still have many, many issues and many fragmented approaches. So the steering committee and collaborative feel that we need a national plan, a plan which can create a roadmap that can give you collective actions to improve well-being of healthcare workforce in order to ensure better patient care and promote population health. We call it the quintuple aim, because by having better workforce, healthy workforce, They can do better job, improve population health, enhance care experience, reduce costs, advance equity. Next slide. Now, I want to point out the fact that we used to call clinicians. Clearly, we realize that's too narrow because we really look at the well-being of all healthcare workers, particularly those who are really in the front line. So you see that recognizing interconnectedness of healthcare and public health systems, we also included public health workers. So you see in the draft plan, we use the word health workforce to refer to direct care providers, as well as those working community health and others. And we use the term health systems to refer both to direct patient care settings, hospitals, practices, as well as disease prevention work in the community. So with that background, I'd like to give you kind of an idea of what we've done. Next slide. First process, the steering committee, which I will introduce you to very shortly, made of amazing leaders from every sector, begin to say, we had a consensus report. That consensus report actually talked about system level changes needed. So using that report as a base, we begin to look at what are the priority areas for a national plan. And of course, each of the area would have goals, actors, and actions. What do you need to do to achieve those goals and who are the actors responsible for them? Then we were able to share the report with 101 of our collaborative members who provide input. And today we have public input from you to give us further comment. And then we will continue to receive comments from you till May 27th. Our plan is to launch this report at the end of June 23rd to be exact. Next slide. Now, this is the distinguished member of the collaborative. And they distinguish in their own right, but many of them are practitioners. They get it. They work closely with the frontline workers. But I would first call out my three co-chairs, Derek Kirsch, who's the president emeritus of the AAMC, and Tom Nasker, who's the president CEO of ACGME, and importantly, Vivek Murthy, the Surgeon General. The Surgeon General cares about this topic, so he has joined us before he became Surgeon General and agreed to co-chair, where he can bring his team to work along with us as you hear about our national plan and his advisory, which will be coming out very shortly. So you can read for yourself the expertise that we have in this group, highly diversified, representing, I think, the whole spectrum of healthcare workforce. Next slide. So these are the priority areas. There's 7. Create and sustain positive work and learning environment and culture. Really important. Invest in measurements, assessments, strategies, and research. But importantly, support mental health and reduce stigma. Address compliance regulatory policy barriers for daily work. And of course, utilize effective technology tools, not tools that's gonna end up with more work, more burden. That's where IT and EHR comes in. But I think important is to institutionalize well-being as a long-term value. While we all jump into action during COVID, we need to be sure that the changes we make are continued, sustained, and we continue to improve as organizations. And importantly, recruit and retain a diverse and inclusive health workforce. Next slide. So you're going to hear about these 7 recommendations grouped into 3 themes later on today. But this slide shows you, very importantly, on the left-hand side, the actors. We say there's a lot to be done, but we call out the people who have to do it. Payers, government, health system leadership, IT companies, academia, healthcare professions, education, accrediting bodies, professional special organizations, and the public. And on the right-hand side, you can see the system map, if you will, putting those actors, as you can see, in the inner circle, and the many actions that need to be done on the outside circle. You can see frequently one actor is responsible for more than one action, and frequently one action is dependent on the many actors. Next slide. So that's where we are. You're going to hear a lot more discussion, but I want to tell you where we're going. First of all, you hear later on from the Surgeon General, they're about to release his advisory, which is the way that they write is so beautifully about what needs to be done. And following this, and they plan to release it next week, following this, ours will be released a month later. It's a 1-2 punch, which allows us to say him to talk about the issues, identify, suggest changes, and ours is a deeper plan to have actions in a deep way. And what this slide shows you is derived from Chris Economos, who wrote about what the social movement is. I think that's what we're looking at. If you look at the 10 elements of social movement, we've already done 7 of them. Starting in 11 o'clock, frame the crisis. 1 o'clock, science-based research. Coalition building, the economics of the situation, the champions, government involvement at 7 o'clock, and a plan which we're now presenting to you. What we're now going to be doing is spark plugs, champions, go to all the organization actors that have them start acting and champion, advocacy, and therefore driving, as you can see in the 8 o'clock environment and policy changes, which we hope will make a huge difference as an entire system culture change for the nation and of course for our workforce. So thank you very much indeed. And with that, I'd like to turn it over to the next session, the moderators, which I believe is Don Berwick. And let me see the slide. I think it's also Rick Pollack, who have a fireside chat with some of our leaders. Over to you.
Thank you very much, Victor. Can you hear me okay? The audio working?
Yes.
Great. Well, I'm pleased to be here with Rick Pollack. Michelle Williams, the Dean of the Harvard Chan School of Public Health, was supposed to be with us, but unfortunately she couldn't make it due to illness. But we look forward to her input as this plays out. She's been a member of the steering committee. I want to begin, Victor, first with just a word of thanks and recognition to you. I serve on the steering committee, but I'll just tell you, your personal commitment, you've showed up at every meeting. Your leadership of this is oxygen for the whole movement, and I really want to commend you for that commitment. And I'm pleased to be here with Rick Pollack, President and CEO of the American Hospital Association. And Rick, a shout out to you too. I just want to say publicly, the American Hospital Association has really shown up full force for this endeavor. Your personal presence has made a big difference. The generosity and the openness and the curiosity that the AHA has shown is just a gift to this whole solving this problem. Thank you so much, Rick.
Thank you.
Why don't we begin with your analysis of the report? What are 3 or 4 key takeaways for you as you've read this report? It's an appropriately complex report, and I don't mean to downgrade any of it, but what are 3 or 4 points that really stick out for you?
Well, first, it's great to be with you, Dr. Berwick. Appreciate your comments, and we very much appreciate the leadership of Dr. Zhao and the Surgeon General in these efforts. And I just want to say at the outset that over the past 2 years, the COVID experience has challenged our healthcare teams like never before. And, I know I speak for everyone involved in this collaborative, as well as everyone that's on this video teleconference, that we are so incredibly proud of our caregivers who stepped up selflessly to provide care during this unprecedented crisis. But as we all know, that caring and compassion and dedication has come with a high price. From the hospital perspective, the NAM effort helps address the challenge of ensuring that we do everything we can to preserve our most precious resource, and that is our people. Clearly, without them, we cannot exist, and the whole system breaks down. And all of us involved in this collaborative share a common goal of caring for the caregivers, those that are on the front lines. And that's why this plan is so important. And we're so pleased to be a part of it. Now, I know today's session really revolves around 3 themes and 7 areas of focus. My job, as Dr. Berwick suggested, is to give you a couple of key takeaways. So I'll give you 4 real quickly. I know time is limited. First, the hard reality is that the healthcare system is faced with 3 big issues right now. And they all existed before COVID: health disparities, lack of access to behavioral health, and the workforce shortages and resiliency. And all 3 of them just became exacerbated as a result of the COVID experience. And all 3 of them are interrelated. And as someone that started their career working for the American Nurses Association 35 years ago, we had shortages back then. We still have them today, but they are of a different nature. And in the words of both the ANA and the AHA, it's now reached the point where it's truly a national emergency, and that's what reinforces the importance of this effort. And I know the Surgeon General is making it a priority for the nation as well. Second key takeaway, I think the plan appropriately recognizes, and Dr. Zhao, I think, made this point as well, that it requires collaborative efforts among all stakeholders. There's no question that there are certain things that are in our own hands, meaning in hospitals' hands, some of which are in the draft plan. And our members have already developed all kinds of caring for the caregiver programs to promote well-being and resiliency that are consistent with the plan, whether it's providing childcare and transportation, referral and retention bonuses, tuition reimbursement and training benefits, paying back student loans, or supporting programs that address mental health and physical health. But as the draft plan suggests, we need to do more. And a lot of that will focus around developing team-based care models that allow healthcare workers from different disciplines and specialties to provide more customized patient care. And that not only allows us to manage medical and social needs across all settings, but also, very importantly, enhances professional satisfaction. But again, and this is the key point here, everyone has a role to play. Academia, professions, insurers, government at every level, just to mention a few. Third point, the draft plan very importantly recognizes that solutions to the healthcare challenges need to take into consideration the changing landscape of healthcare delivery. And just think about all of the changes that we're seeing. The movement toward value-based payment, however you want to define it, is going to have an impact on staffing. The increased use of telehealth, remote monitoring, and other technologies will impact staffing and resiliency. We need to change workflows to value well-being as a critical element to providing patient care. We need to consider, and the report points this out, the regulatory burdens that are imposed on the healthcare workforce that force providers to deal with all sorts of administrative requirements that take people away from the bedside, away from providing care. And the movement toward addressing social drivers of health, which is linked to a lot of folks in the community and society. If we're really going to deal with that, that requires changing in staffing. And while we understand that hospitals are always going to be there or work to be there for providing emergency care, sophisticated surgeries and diagnostics, the reality is we are also cognizant of the need to redefine the H, to move to provide care where it's convenient for patients, to meet them where they need the care, which sometimes involves hospitals at home and other different alternative sites of care, which again impacts staffing. Fourth and final point, Don, because I know we have a limited amount of time here, the draft plan also recognizes, and we are totally committed to ensuring that hospitals are safe, open, and inclusive. When it comes to ensuring physical safety, we have our own Hospitals Against Violence campaign focused on prevention and intervention. We've partnered with the Department of Justice and the Medical University of South Carolina to provide support programs for those communities faced with events of mass violence. We've asked the Attorney General and the Congress to make assaulting a healthcare worker a federal felony crime. The plan also recognizes, and again, we're totally committed to addressing systemic racism, discrimination, and bias. This is intricately linked to the workforce and making it an environment that is safe and an environment that is inclusive. And we recently launched this equity roadmap here that we're absolutely committed to, that gives hospitals the ability to evaluate their own internal culture and develop concrete steps to address the issues and improve. So thanks for giving me this opportunity to share some takeaways from our perspective. Again, it's been an honor and privilege to be a part of this action collaborative. And by the way, it's instructive that we call it an action collaborative, because I can't stress enough the need for both action and collaboration. Thanks, Don.
Well said, Rick. We have a few minutes for a couple questions I'd like to pitch to you and just get your thoughts about. Let me ask the first one, which is sometimes when we've got a problem or a crisis, we have to kind of convince executives, boards, leaders, that they better pay attention to this. What's the situation now? If you go around the country as you do and you speak to hospitals and boards, how high on their strategic radar is this particular problem of well-being of clinicians?
You know, it's the highest level. When I ask hospital CEOs, I feel like it's a cliche for some people that we've talked about this before. I ask them, what are your 3 top priorities? And they say, number 1, workforce, number 2, workforce, number 3, workforce. It has risen to the highest level of everyone's agenda, and everybody is focused now, not only on what these kinds of roadmaps may provide, but also we're focused on pumping out creative ideas that are actionable today, because we have a real problem right now. And some of this that's recommended, you know, will take some time, but we need to move real quickly.
That's good news that we don't have to sell the problem. It's now it's time for solutions. But you read my mind about this, the next question. And so what about urgency? It's a complex set of ideas, all important, 7 categories. Are there any that you say, look, guys, let's hit it now? What would you put at the front end of the urgency, if that's not asking you to be a little bit, not putting on the spot? What has to happen now?
I mean, you know, boy, there's a long list of things that need to happen now. And I think that, you know, you have to put things into 2 categories. One is retention and the other is recruitment. When it comes to retention, it's the kinds of things that I mentioned before, where we can really focus on retaining people through the different approaches of helping them with childcare, helping them with transportation, helping them with student loan repayments, those kinds of things. Not stigmatizing people that reach out for mental health reasons, making sure we begin to move toward team-based care. And then there's the longer issues with regard to increasing the pipeline. And, you know, we really need to focus on nursing faculty. 90,000 or 89,000 qualified nursing students were turned away because we don't have enough faculty. So that is an important part of increasing the pipeline. So those are the 2 areas, of course, that we need to pounce on.
Thanks, Rick. I know you've had some helpful thoughts in the AHA about do now, a little bit later, and then long term. And I hope people will read that out of the report and get more counsel. You mentioned nursing. Let me go there. There has been a slight misperception sometimes about this National Academy work that I've heard on the street, that it's about physician burnout, physician. That's certainly part of it, as Victor made clear. It's really about everybody. So I'd like you to talk about nursing for a minute. I know as a physician that the nurses are really the heart of the system. Can you make a few comments about implications for nursing about getting this right now?
Well, you know, I think for nursing, of course, they are the backbone in so many ways of the healthcare system. You know, not to slight anybody else, but you know how much we all rely on nursing. And I think that so much of what we hear from the nursing community is really the need to change the care model, and the real need to focus on team-based care, the ability to allow all of our nurses to practice to the height of their abilities, and to take away the burdens that are maybe put on them from doing things that could be done by other people. And the whole notion of team-based care, when we're focused, and you've been such a leader in this, Dr. Berwick, in focusing on coordinating care across the continuum and improving care, you know, that relates to teams of various disciplines that are focused on providing care across a variety of settings. And I think that that's what could help our nursing community as much as anything else. I would also say that there are certain things that are going on that that we all need to pay attention to, and that is, you know, the violence issue. And a lot of that has to do with misinformation about public health. And at the end of the day, unfortunately, the nurses on the front lines are the recipient of that kind of disrespect that we see as a result of that. And I think whatever we can do as a collaborative, as a society, to deal with that, so that will take some stress and pressure off.
Thanks, Rick. We just have 1 more minute, so 1 more quick question. In your remarks, you really went pretty far in thinking about this as a time when we got to really rethink the whole structure and flows of care in the healthcare system. There's a time for restructuring. Part of that has been brought to us by the pandemic. The pandemic has been, to say the least, an immense tragedy. And many of the workforce issues we're facing existed before. But what is the pandemic? What lessons have come to us because of the pandemic that even you or I might not have realized before, that we really need to start to change the way we think now that this crisis has brought us this unwelcome lesson?
Well, there are a lot of lessons, the public health care infrastructure, that needs the support that it doesn't get, where hospitals became the de facto public health agencies in many communities as a result of that. We already talked about team-based and cross-training is an important lesson that we learned. Another important lesson is the supply chain. That affects everybody in the hospital setting, in the provider setting. And look at what we're dealing with now with contrast media. We should have learned that lesson a long time ago about relying on one vendor primarily from one country. The other thing that I think we really need to revisit is the National Defense Medical System. That backup system, the reserves, if you will, really did not work in the COVID crisis. Because that was designed to deal with circumstances of limited duration in a regional or local basis, wildfires, tornadoes, floods, hurricanes, and the backup system, the reserves, if you will, didn't exist. And that system is built on volunteers from our own organizations who, in a nationwide emergency, weren't going to leave our communities. So those are the lessons. We've also learned a lot about how to set up alternative sites of care, how to make our physical plant more adaptable and flexible. But boy, that list goes on and on.
Thanks. Well, Rick, thank you again to you personally, to the AHA, for your leadership and participation. We're in this together, and I really appreciate the chance to talk with you.
Thanks,
let me pass it back to you, Victor. I believe, are you next?
Thank you so much, Don and Rick. We're going to transition into theme 1, starting with Barry Rubin.
Thanks very much. While I see many of the recommendations in the national plan that we'll discuss today through the lens of a vascular surgeon working at a large teaching hospital, I think that many of our actions to cultivate positive culture, promote well-being, and decrease burnout will be valuable to consider beyond healthcare settings and will apply to learners as well as individuals who have completed training in their respective fields. As I think most on the call know, burnout has a negative impact in 3 main areas: patient outcomes, healthcare workers themselves, and health system finances. One of the key objectives in the national plan is to create and sustain positive work and learning environments, and to promote cultures that improve health worker well-being and decrease burnout. To accomplish this objective, frontline staff and health system leaders must establish a culture of well-being that is integrated into strategic plans and organizational values, health system operations, programs, and services, and their approaches to teaching. This could include implementing wellness onboarding programs for students as they enter health profession schools to build coping and resiliency skills, and training opportunities for faculty to help them integrate approaches to well-being into educational programs. It's crucial that healthcare institutions recognize the positive impact that equity, diversity, inclusiveness, and accessibility have on healthcare worker well-being, that they adopt accountability standards and best practices that promote healthcare worker well-being, and invest in adequate, flexible staffing plans that allow for safe patient care. Taken together, these initiatives will increase health worker retention, decrease turnover, and improve patient outcomes. A related objective of the national plan is to invest in measurement, assessment, strategies, and research directed at improving well-being and decreasing burnout. Here, the axiom, if you can't measure it, you can't manage it, directly applies. Healthcare organizations must be equipped to collect and report data on health worker well-being and burnout, and importantly, to identify the drivers of burnout in their local environments, which might include challenges associated with health IT, regulatory practices, payment, workload and staffing models, local culture, professional fulfillment, and as we all know, more recently, the impact of COVID-19, both at work and at home. Data should be collected using survey tools that have been validated for use in healthcare settings and that can be used to assess well-being and burnout in all members of the health workforce. As Victor emphasized, including learners. The choice of which survey to implement is much less important than the decision to actually use a validated survey and report on the well-being, the prevalence of well-being and burnout over time. Measurement should also include assessment of core leadership behaviors that promote workforce well-being. With this information, health systems big and small can develop strategies to improve well-being and decrease burnout that are tailored to their local environment, implement these strategies, and then repeat this validated surveys to determine if the strategies that they implemented actually improved health worker well-being and decreased burnout. Research should be directed at understanding organizational, learning environment, and health system factors that contribute to burnout, the intention to leave the health field, and tragic cases of death by suicide among health workers. We also need to understand the impact of discrimination, sexism, and racism on the professional and personal well-being of health workers and learners, the immediate and long-term effect of COVID-19 on the well-being of the health workforce, and the linkage between burnout and the key performance indicators most relevant to healthcare organizations and the learning environment, such as quality of care, patient-reported outcome and experience measures, and staff turnover. In the national plan, we propose a commitment to evaluating health worker burnout and well-being as a quality and performance metric that all health and education settings should report. Further, we propose that federal entities advance a coordinated research agenda on health worker well-being and create and manage a national registry of evidence-based interventions. Internal and external funding streams, which could take the form of public-private partnerships, will need to be identified to support measurement of well-being and burnout and to enable the development of effective intervention strategies. By widely sharing this information, health systems could determine which strategies to improve well-being and decrease burnout might be effective in their local environments. I'd now like to ask Michael McGuire, academic hospitalist at Christiana Care and Alfred DuPont Hospital for Children, and Noelle Smith, Senior Director, Physician Assistant and Industry Research and Analysis at the American Association of Physician Assistants, to both provide their perspective on the chapters in the national plan that address assessing and cultivating work and learning environments. Michael?
Thank you, Dr. Rubin, for that overview. I'm excited for the opportunity to focus my comments on one of our priority areas you've already mentioned, the importance of creating and sustaining positive work and learning environments and culture. As a member of this committee who represents the early career physician recently out of residency training, I work primarily within the hospital on the front lines as an adult and pediatric hospitalist and core faculty in our residency training programs. While in residency and now as a junior attending, I have personally experienced and witnessed my colleagues and trainees experience burnout and the hardships related to work in the clinical learning environment, as I've also experienced personally. The national plan brings to light how crucial it is for patient care, as well as financial drivers, to commit to the well-being of our workforce and trainees, to retain them, and to allow them to thrive. To do so, it is going to be crucial to continue to develop accountability frameworks in order to ensure physical and psychological safety of health workers, something that over the past 2 years with the COVID-19 pandemic, we have seen was lacking or fragile at best. It is important to understand this is a systems issue with solutions that start at the top but are also bidirectional and requires input as well as action from all stakeholders. In particular, whilst we not forget seasoned clinicians and staff, our trainees are a precious resource and a vulnerable population. With any new health worker, whether resident physician, nurse, or support person, which we must not forget includes assistants, phlebotomists, and environmental staff, among others, healthcare organizations must provide the appropriate onboarding and preparation for their employees' well-being, as well as identifying and highlighting resources to ensure their ongoing success in order to maintain a culture which is conducive to ensuring sustainability. There must be attention paid to the physical and psychological safety of healthcare workers that is inclusive and lasting. This must be done through constant assessment, adaptation, and quality improvement within the system to foster a culture that cares. The second chapter of the National Plan for Health Workforce Wellbeing targets multiple areas for improvement and action items on how to get there. In sum total, likely each will be necessary for success. However, as a frontline worker myself and core faculty to approximately 200 medical students, pediatric and internal medicine resident trainees every year, I can say that an understanding of total workload, which includes both hours worked as well as the complexity and nature of the work itself and the tension with education and life balance, is crucial. Finding joy and elevating meaning in our work for me means being able to provide the highest quality patient care and education that I am capable of providing. To do this, the plan highlights ways to develop frameworks and through healthcare leadership structures, such as implementing a chief wellness officer and team, which you will continue to hear about throughout this meeting, that can focus on maximizing the clinical learning and working environment as they overlap. Personally, I am an advocate the most for a reduction of administrative burden that does not contribute directly to patient care, safety, or education. Developing high-functioning interprofessional teams whose members practice at the highest scope of their training, and identification and mitigation of additional stressors which often are external to the healthcare system, but affect us deeply and individually, such as enough time and space for family planning and to be able to care for your own personal health and your family, regardless of composition, and attending to life's daily tasks so that our workers can thrive both at work and at home. Currently, for many, myself included, this can be a daily struggle, but this is a crucial time for me personally to be well and to be able to role model appropriate wellness and resilience to my trainees, as well as have the resources to direct them towards in the time of need. The plan outlines areas where additional assessment, research, and improvement can be accomplished, which will be best highlighted by my colleague, Noelle Smith. Thank you so much.
Good afternoon, everybody. We know that healthcare workers who find joy, fulfillment, and meaning have greater engagement. As I have watched the conversations progress over the past 5 years, I have cautioned against putting self-management of well-being on individuals themselves. Approaching supports for all healthcare workers from a systems approach is critical, and the work of the National Academy of Medicine has highlighted that need for a systems level approach, and that if we want to improve the health of our healthcare workers. There is no single thing that causes burnout. There is no single intervention that could be the change. There is no one intervention that can create a culture of well-being. What we know is that a well-coordinated plan is truly needed to address the needs of the healthcare workforce if we are to ensure a culture of well-being for all in healthcare. The same is true for research. That is, we need to understand the drivers of burnout and how changes affect every aspect of the healthcare system. That well-coordinated plan is necessary to take the existing research, which today has tended to focus on limited segments of healthcare, and move it towards a more comprehensive look at the issues. This will involve collaboration between entities such as professional associations, research entities, educational institutions, healthcare systems, and the workers themselves. Funding is needed to support this work. We have seen this start with the passage of the Dr. Lorna Breen Healthcare Provider Protection Act, and I hope that is a sign of things to come. Furthermore, we need to create and incentivize partnerships between organizations within professional and educational associations, academia, and research organizations, as well as within healthcare systems. These partnerships could improve our understanding of how healthcare teams can be optimized, allowing for everyone to work to the top of their abilities while attaining the best patient outcomes with the least amount of burnout and distress in the healthcare workforce. I also want to stress the importance of epidemiological tracking for burnout for all workers, not just select segments, sharing the data to assess the trends over time, and sharing that information for systems, for professions, for populations. That will further strengthen our understanding of how changes to the practice environment drive change for the individual. As the healthcare systems in their entirety move towards supporting the National Academy of Medicine's National Plan, research will be needed every step of the way. More importantly, the changes made and the research to enhance worker well-being must include all workers. All populations need to be represented and systems types must be included. We have just heard about the priority areas of measurement, assessment, strategies, and research. But I do want to underscore that researchers will help advance every priority. It should not exist just within this one area. We need to look at how change and interventions impact the entirety of the healthcare system. And I look forward to hearing more from the next speakers as we learn more about the National Plan. Thank you.
Thanks very much, Michael and Noel. I would emphasize the importance of integrating approaches to well-being and decreasing burnout into culture of organizations. The fact that we're talking about all healthcare workers, not just physicians or nurses or allied health, the requirement to measure and report these outcomes, and that there is no one size fits all. So organizations need to do the work to measure the drivers of burnout at their local environments and then develop appropriate strategies. I'd like to now ask Christine Castle, Professor of Medicine at UCSF and Collaborative Co-Lead, to discuss our second theme, which will address barriers to health workers' daily work and the promise of technology. Christine?
Thank you, Barry. Let me start by saying what we've heard already from the speakers today is about all of the different stakeholders and parts of the healthcare system, and every single one of them has a role to play in reducing burnout and increasing clinician well-being. Our group looked, and these two chapters really represent a look at what can really be done at the national federal level, particularly with the leadership of the National Academy of Medicine and the support of the Surgeon General. And so the two areas that came up, one was addressing compliance, regulatory, and policy barriers. In almost every survey that is done of healthcare, particularly of clinicians, the number one obstacle, barrier, frustration that they feel is from what you might loosely call bureaucratic requirements. And this is documentation requirements, other kinds of regulations, lots of checkbox things, all things though that require interfaces with the EHR and with time away from the clinician. These new technologies, such as the EHR, have brought tremendous data wealth and ability to use data in lots of ways, but they were by and large implemented without rethinking the workflow that could so easily be made much more efficient using these kinds of digital technologies, but instead added frustrating work to the work of clinicians and did not include a deep look at the human factors involved in how you reframe the workforce and the flow of the work through the day, as well as the function of a team in healthcare in a way that reflects smart use of technology, not an old-fashioned use of technology. So on chapter 5, one thing we look at is what can be done at the federal level to reduce some of these requirements. And so one of the first points is we need policies that address both the hybrid virtual and in-person workflow and facilitate a way of getting work-life integration. This is something we learned a lot about during the COVID pandemic, and you'll hear more about in the next theme. Secondly, that to get the leadership organizations together, CMS, ONC, and the private insurance industry, to look at all of the documentation requirements, which ones are really necessary, and how can they be done more seamlessly without actual input and fingerprints of clinicians who ought to be facing their patients, not facing their computers. How can prior authorization be made more seamless and more easy and reduced and eliminated where it really isn't necessary? How can healthcare workers be enabled to really practice at the top of their training and education? And how can interstate practice be simplified to enable virtual services, telehealth, and less burden on the individual clinicians for all of the requirements that vary from state to state? How can all of that be enabled by technology rather than made more difficult by technology? And that really gets to our second chapter, chapter 6, engaging effective technology tools. While if you look again at these surveys, you see that the EHR is one of the #1 problems that people name as a cause of burnout. Digital technology actually can be a source of relief and has great promise for improving work experience and patient experience. Those two things together. And that's really the North Star. That's really what we ought to be looking for. So think about voice recognition. Think about artificial intelligence and machine learning. Think about all of the ways that digital reminders could be more efficient and more human-centered and not just annoying and irrelevant to the patient in front of you. Think about how information science should be able to gather the information you need to take care of that patient that day and not have to page through dozens of clicks in order to get to the information that you're looking for. Well, these innovations are occurring out there, and what we do is call on national policy to find ways to foster more innovation, faster innovation, and adoption, including to make these kinds of tools available and affordable to lower resourced environments. So they have to include one of the things that the federal government can and should and does do so well is set standards of interoperability across disciplines and across platforms to enhance team-based care so that the information is shared, and across different care settings as well, including long-term care and community care. That new technologies must be both clinically useful and accurate, of course, and they must be designed with users, in partnership with users. Technology innovations need to increase personal connections with patients, and that ought to be a standard as well. And finally, that the use of technology isn't established as an enabler to streamline care and a way of not adding one technology on another, but finding ways to peel away the things that are unnecessary in order to really take advantage of digital technology in the way that so many other complex industries do. So we're really delighted today to have two experts for the front lines to be able to comment on this theme in these two chapters. The first is Jennifer Martin, who's the nurse and a senior director of clinical informatics at the Carilion Clinic. And the second is Eric Fornari, a pediatric orthopedic surgeon and vice chair of faculty affairs at Montefiore Health System and Albert Einstein College of Medicine. So first, I'm going to turn to you, Jennifer.
Thank you, Christine. And thank you to all the members in the committee who developed this plan. This is indeed critical work for all of us. I'll just add a few remarks regarding a couple of the areas addressed in these two chapters. Related to regulations and policy barriers, each of our organizations spend a large amount of resources and time interpreting and determining application for rules and regulations. The need for our regulatory bodies to assist with interpretation and clarification is critical to promote broad application and standardization of practice. This upfront clarification can reduce the burdens related to individual interpretation. And considering the technology tools, much of our higher level technology of today, like Christine mentioned, involves artificial intelligence and/or machine learning. These are important tools to aid clinicians, but require thorough assessment of impacts to workflows and cognitive load. When thorough workflow impacts are not reviewed, these tools can potentially negate positive impacts for both our patients and our clinicians. Many of our clinicians are distrustful of AI or machine learning. Careful and detailed workflow examination is critical to ensure that AI tools will perform consistently within specific nuances of the individual organizations. Items such as variability of data flow and timing with these tools can add distrust and frustration among end users if they're not all carefully examined on the front end. Educating and incorporating these types of tools into practice is often challenging and will benefit from further study as we go. We must be thoughtful with implementation and recognize the continued maintenance needs with these tools to ensure a positive benefit for both our patients and our clinicians. Today's clinicians' cognitive load is tremendous. We must establish partnering with our human factors and systems engineers as routine. Human factors and systems engineers examine workflows from within and outside of the technology. They can be our collaborative partners in designing and redesigning our clinical workflows that incorporate technology that is user-friendly, efficient, and safe. I am so pleased to see that these recommendation themes are included in the plan for our health workforce well-being. These are just a few of the important concepts addressed within these chapters that I wanted to highlight today. I want to thank the committee for asking me to make remarks. I'll turn it over to Dr. Fornari.
Thank you. It's an honor to be here and speaking and representing. I will give a disclaimer that I'm not really a technology expert, but I think that we all become technology experts in the field that we are chose to work in every level. So I think of myself as someone that sort of came into medicine, had paper charts initially, and then experienced the EHR and the electronic revolution we've had. And so I think sort of like spanning pre-cell phone and with cell phone, I think that experience is different for those of us because we sort of saw how it was before. And I think the adoption of these technologies has been great on so many levels, but certainly there's room for refinement and ways in which we can make them work better. And I think what we need to do is really think about what we need to do to make our lives better and make our work life easier. And like so I said earlier, there's not a one size fit all. It's different for an outpatient setting versus an inpatient, for a doctor versus a nurse. And I think assessing how we have the medical records and what we're doing and making sure we're adapting to each of the different clinicians that are engaging with it is important. And we need medical records that speak to one another. Like it really makes a huge difference. And figuring out how we can do that as we have so many different EHRs already out there, I think is key, because I think it really does enhance patient care and make the physician's life easier knowing what someone else went through without having to go through loops to get it, and the technology is there. I talked at the last webinar about virtual scribes, and I think that got me keyed into this a little bit, but that's a pilot that we've run here, and sort of one example of technology that's out there that we can adapt that can really have a profound impact. And why it might not work as much in my orthopedic practice and some of my family practice and general practitioners, it was life-changing for them to have a virtual scribe to use. And I think it's one of these technologies that's accessible and here now. I hear a lot about AI these days, and I think that we're in the infancy of that, but I think it's important to cultivate that and really figure out how it can impact our workflows, not just being an overall theme, but what it can do clinically to make a difference for us based on our specialty. And I think all this takes investment, and I think that's the biggest push. Like, I think there's a lot of great things out there, but we need to get access to it, and that will take a commitment from the federal level, the state level, and the private sector to help us bring these technologies to places that don't always have the resources to build on them. COVID gave us telehealth and video visits, which I probably would have, I don't know when I would have seen it at Montefiore, but I think that we were able to push to do that, and we proved that we can do it. But further development of our technology will take investment, and some places have more resources than others, and some places are further along in this journey, and we need to key into those places and use the lessons they've learned and bring it out into the greater public and the greater institutions to utilize. And that will take commitment and integration of those practices and a vision of the greater good, because there are a lot of issues that can rise up to prevent that collaboration and sharing, but I think that it's vital, and it will take money, and we need money to come from every level and trickle down to every institution so that they can have access to it. And so I think that that will put the power behind the words that are here, because there's so much that technology as a whole could do for us, but it's really getting it on the ground and helping find the ways that each individual system needs help to implement it and what works best for that system and to have access to be able to do that. So I think the framework is laid. I think this is a phenomenal plan, and it will have a very strong voice and a huge impact. And I look forward to working with everyone to continue to bring it forward, because this technology is here to stay. We're going to take the next step with AI, that we're going to learn how to utilize that. And it's an ongoing evolution, like everything else in medicine, that we adapt to and learn from. It's different from when we started 20 years ago to where we are today, and 20 years where we'll be from now. So I think it's important that we stay on the forefront and help each institution do that.
Thank you, Dr. Fernari. I'm going to now turn this over to Pam Cipriano, who is the Dean of the University of Virginia School of Nursing and President of the International Council of Nurses. And Pam is going to lead a discussion on theme 3, the effects of COVID-19, and what we've learned on from that on the well-being of the health workforce. Pam?
Thanks very much, Chris, and thank you to all our presenters thus far. Hello, everyone. The National Plan envisions a future state where patients are cared for by teams of clinicians and learners who are thriving in an environment that nurtures and fosters their well-being because they're supported, appreciated, and kept safe. We've witnessed the assault of COVID-19 on workers' well-being, their physical and mental health, their psychological safety, and their exodus from the workforce. We recognize the high toll of prolonged stress, but even in the absence of a pandemic, the reality is that healthcare workers experience increases in depression, anxiety, and suicidal ideation before and when they enter the health professions, and these high rates persist throughout their careers. But the repeated stress injuries of the pandemic have only caused further erosion of physical and mental health. The actions called for in this section address 3 major areas: mental health and reducing stigma, prioritizing and making a strategic commitment to sustaining well-being of the workforce, and restoring the positive aspiration to be part of the nation's healthcare workforce. For each of these areas, we call for action to address system challenges of high workload, administrative burdens that you just heard of, and protection and safety of workers, accompanied by support for work-life integration and investment in policy changes that value the healthcare workforce. First, in Chapter 4, we emphasize that to improve mental health and substance use, steps are necessary to ensure there's a future where the culture of silence is no more, and where we seeking mental health care is without stigma and negative consequences. So there needs to be measurable decrease in workers who develop mental health conditions. So prevention is important. The easy access to resources that are affordable, confidential, and paid for must be commensurate with addressing improved well-being. That's going to require building the number of practitioners in a number of categories and improving pay parity among professionals. continuing to use virtual options for delivery of services, and allowing time for individuals to access those services is expected. We also recommend establishing peer support programs and stress first aid to augment employee assistance and other formal services. Next, in Chapter 7, we propose that in the future, well-being is a given for the healthcare workforce. Institutionalizing well-being as a long-term value is one of the best strategies to secure the commitment and accountability of leaders in all practice settings, including throughout the public health workforce. And we know clinicians and entire teams have suffered from the extreme impact of prolonged COVID-19, which is exacerbating the burnout pandemic. The stress injury from repeated personal trauma, from fear, fatigue, death, and loss of psychological safety and a sense of humanity has taken its toll. Healthcare workers in all roles, however, have also told us they did not feel valued throughout the pandemic, and that still holds today, that they felt there was more concern expressed for financial viability than workforce viability and vitality. And we've seen the disastrous result, an erosion of well-being and an exodus from the workforce, or an expression of intent to leave. Strategies to embed well-being as a value will help us restore meaning in work and shift the narrative from a focus on productivity to one of well-being that allows clinicians to do their best and safest work. Adopting practices aligning with the first theme that you heard, positive work and learning environments, will also reinforce to workers their value and caring about their welfare. As well, strengthening our public health and care systems acts as a preventive measure for protecting workers as well as the public. In the collaborative's recent convening about this very strategy of embedding a value of well-being, we explored the challenges on this journey with 3 health systems. And we know that it is a journey that requires dedicated effort, collaboration, and investment. By living well-being as a value, we guard against active forgetting of the raw effects of the pandemic and utilize lessons learned to stop reinforcing the trauma. Our third area, Chapter 8, planning for the future workforce, demands recruitment and retention strategies that respect the needs of workers from all walks of life and achieves a workforce that reflects the U.S. population. Opening doors and creating multiple pathways and opportunities will require investment to enable more individuals to pursue health careers. Treating the health workforce as a national asset means ensuring person-centered and safe environments, as well as support for workers to improve the health of the nation. Together, all of these efforts can lead to improved retention, a critical need now more than ever before. We aim to reset the vision for a vibrant, respected, supported, and thriving workforce in every discipline that restores the aspirational qualities of entering and remaining in the healthcare workforce, where experiencing joy and fulfillment is the norm. These actions are transformational as we optimize an investment in well-being. We ask our healthcare workers to care for the nation. It's time we demonstrate we care for them. I'd now like to introduce our 2 distinguished panelists. Our first will be Stefina Danso, a registered nurse at Montefiore Medical Center, Wakefield campus, and Nashika Knight, Director of Workforce Transformation at the Association of American Medical Colleges. And they're going to share with us experiences about the importance and impact of being supported, as well as successful approaches for both teachers and learners. So we'll first start with Stefina Danso.
Good afternoon. I want to thank NAM for the opportunity to share the challenges experienced by the health care force during the COVID pandemic and afterwards. The objective of NAM to address clinical well-being and resilience is commendable and appreciated by frontline workers. We encourage you to continue and move forward with this noble and much-needed resource and pathway to wellness. I am a registered nurse. I'm a bedside nurse in the ICU. I work with a very vulnerable population in the Bronx, New York. It was helpful as a frontline worker during the worst times of the pandemic, being able to share with my coworkers the experiences that we were going through, being able to share with my colleagues, because they were the ones that were in the trenches with me. It wasn't easy to try to share with my family. I have young children. I have a 4-year-old, a 5-year-old. I live with my husband, but they wouldn't be able to relate with what was happening. Prior to transferring to the ICU, I was orthopedic med-surg nurse, and I never had a dead patient. I never had anyone, another human being in my care, die. So when COVID happened, my very first patient, I will never forget her. I'll never forget her face. When she came, I remember before she was intubated, she was able to speak with her family because she had her phone. When she passed, I didn't know what to do with myself. I cried. I had time to get myself together. But it didn't stop with just her. It kept happening. This was very traumatizing. I didn't want to share that with my husband because I also didn't want to traumatize him. When our patients were being intubated, our COVID patients were being intubated, we had done everything. And there was a sense of knowing that they weren't going to come out of that intubation. And this was really heartbreaking. When you meet your patients for the first time, they're talking, they're telling you what's happening. You see the distress and fear, the worries. And then when you get to the point where you've done everything for them and you know this is the last moments they're about to have from one human being to another human being, it's distressful knowing that there's no more you can do. You're about to intubate them to give them a chance, but the chances are so slim. We held their hands, and my coworkers, my colleagues, they were very good. As the primary nurse, usually I would be the one taking care of the medications while they're being intubated, but my coworkers saw that. They would come, another nurse would come and take care of that so that I could be the human person who would hold their hands and be there with them. At that time, family and friends couldn't visit you. When you were taking the last moments that you had in life, there was no one there. If no one was there to hold your hand, there's nobody else there. Sharing this experience with people outside of the healthcare system or persons who didn't experience those, it's not easy. And even till this day, I don't discuss that with my husband because, like I said, it was traumatizing for me and I didn't want to traumatize him. It was scary because when you go to work, the chances that you could bring something home, COVID home to your kids, to your family, they were high. It was very present every day. So the camaraderie of my colleagues, it was so valuable. It was so needed. Being able to share those experiences emotionally, it was cathartic and it was helpful because you felt you weren't experiencing this alone. The world, we didn't know where COVID was heading and it was happening everywhere, but you knew coworkers were there for you. They had your back. They were in your corner and you would get through it together. So that experience, being able to share that and our facility facilitating that, that was so useful. The other thing that was very helpful, and I commend Montefiore for doing this, was opening up the care center, which is our wellness center, to the employees. The wellness center by Montefiore was initially created for family and friends of the patients. But during the pandemic, you couldn't visit the hospital. So they opened it up to us. This was a great idea. This was one of the best things they could have done. The care center provided an oasis, a place that you could step away off your unit. Because when you go back to your unit, the chaos was happening. But when you stepped into that room, it was a different place. The atmosphere was different. There was waterfalls. There's pictures of cherry blossoms on the ceiling. Coffee, free tea, snacks was there, and the care providers, they were genuine. They were kind. They would make the coffee for you. I know how to make coffee. I could make it myself. I could make tea myself. But they would go through the trouble of making it for you. They would listen, and you could tell the genuineness of that. I felt that Montefiore, having that, they were communicating to me that they appreciated my sacrifice and my service. Because leaving my children are young, 4 and 5 years old, they need me. They need me to teach them right and wrong, teach them to respect others, to teach them that, they have to value other human beings because they have great value. They need me to pay the bills. So it was a sacrifice. And I felt opening this up to employees, I was being appreciated. My sacrifice was not going unknown. And I want NAM, I want the committee to know the wellness centers are valuable. It communicates something, even if it's not said out loud, indirectly, you can feel it communicates that you are appreciated. The wellness center is a place where you can take a deep breath, you can close your eyes. It's a calming environment. It's a place where you can bring your feelings and your stress, and it was confidential. So these two things, the camaraderie and sharing, and the wellness center, they were very valuable during the pandemic. As a frontline worker, as someone who went through this, these were things that were very valuable and helpful to me, even being able to process my own emotions and understand what was happening and be able to get through it well. Thank you.
Thank you very much. Nishika, please.
Good afternoon, everyone. Thank you for the opportunity to share with you this afternoon on behalf of the Association of American Medical Colleges and talk a little bit about our efforts to diversify the physician workforce and how we think these might impact the overall health and well-being of the nation's healthcare workforce. 9 months after the onset of the COVID pandemic, Dr. Deborah St. Fard penned these words: "I am a Black woman physician, and I live at the intersection of physician burnout, the COVID-19 pandemic, and systemic racism." The global COVID pandemic, coupled with increased requests for anti-racism initiatives, necessitated rapid adaptations across medicine and intensified the demands placed on people of color. In a 2019 article in Academic Medicine, Tiffany Carson and her team suggested that many institutions' well-intentioned diversity and inclusion efforts unduly burdened faculty and practitioners from underrepresented groups. The authors concluded that this minority tax extends beyond committee work to include disproportionate mentoring demands and is even greater for individuals who exist at the intersection of multiple minoritized identities. One way to mitigate burnout among diverse healthcare workers and educators is to build a critical mass, enabling people of all backgrounds to find community and belonging, and institutions to cultivate learning and practice environments where everyone can thrive. We all aspire to create a workforce capable of providing equitable, high quality, compassionate, and culturally responsive care to all patients and communities. Diversity is not a means to that end, but it is an essential part that will get us there. AMC's Strategic Action Plan 4 addresses this foundational need by focusing on collaboratively making the pathway to the health professions more desirable, accessible, equitable, and attainable for Black, African American, and American Indian Alaska Native communities, and those who will be the first in their families to obtain a college degree. The plan concentrates on addressing structural, institutional, and individual factors learners navigate on their educational journeys, and on uplifting effective models, programs, and practices. Our approach is multi-pronged, iterative, data and practice-driven, phased, collaborative, and most importantly, informed directly by the learners and communities themselves. Our strategic goals in this plan include supporting capacity building for pathway programs, conducting a needs assessment of learners in middle school through residency and fellowship, their families, mentors, and educators, enhancing and creating resources for future healthcare workers, developing systems-based resources, tools, and models for medical schools and other institutions, and leveraging the joint AAMC-NMA Action Collaborative for Black Men in Medicine and other strategic partnerships. Through concerted, coordinated, and collective action, Action Plan 4 aspires over time to turn the historically diverse 2020 to 2021 applicant and matriculant pool from anomalous to ordinary. We're in the early implementation phase of this action plan. And because we know that diversifying the workforce will require systemic change across multiple sectors, our approach is multifaceted, building and sustaining the pool of candidates, preparing them for health careers, promoting anti-racist admissions and selection policies, practicing integrated holistic student services and medical education, and equipping medical schools to support the mental health and well-being of all students and trainees, and most specifically, those who are from historically marginalized and excluded populations. To that end, one of our strategic partners is the STEVE Fund, an organization specializing in supporting the mental health of students of color. I recently shared an overview of our strategic action plan at a National Healthcare Pathway Program conference, and a high school student in the audience stood during the question and answer period and lamented the diminished mental health and increasing burnout rates of students long before they enter college or professional programs. There's a demand for understanding the dimensions of wellness, building individual resilience, normalizing health seeking, and fostering healthy classrooms and clinical environments long and early on the trajectory to the health professions. Our desire as the AAMC is to transform the healthcare workforce to improve the health of people everywhere, and well-being is an important arm of our work. We don't just want learners to enter medical education, we also want them to bring their full selves, all of their salient identities, to thrive and to enter the healthcare workforce and find meaning and belonging. This, we believe, will create longevity. We're excited about this work, and we look forward to continuing to partner across the health professions. And we're grateful for this opportunity to share with all of you today.
Thank you so much, Stefina and Nashika, for sharing your personal story and sharing great opportunities for us to build the new healthcare workforce, especially with diversity and representation. I'd like to now turn things over to Dr. Daryl Kirsch, who's one of the collaborative co-chairs and president emeritus of the American Association of Medical Colleges, who will moderate our Q&A. Daryl.
Pam, thank you so much. This has been just really so exciting to hear. And I want to circle back with some of the questions people have posed on the chat, and also with some of the questions I have. And I want to start with Rick Pollack, if you're still on. Rick, I hope you are.
Yeah, I'm here.
So when a CEO says, what do I do? You know I have this problem. I hear it from my medical staff, my nurses, all my employees. What do you think should be their first steps?
You said when a CEO hears that?
Yes, when you hear that from a CEO.
Well,
when they say, I know I have a problem, but what are the steps I should take?
Yeah, okay, I got you. I think one of the most important things to understand is that every community is different, and there may be needs that are very different in a lot of different settings in a lot of different communities. And I think the first step for me, and the first thing I would recommend, is listen. You have to listen to your workforce. You have to listen to the folks that are part of your organization and make a determination as to what is the best approach. I was listening very carefully what Stefina talked about in terms of what Montefiore did in terms of providing a safe place. That's something we hear a lot of people are doing, and that's very important. So I think listening to what people need, because there are going to be differences in different places. There isn't a silver bullet, as you would say, to just fix everything.
So that really fits with the theme we've heard throughout the work on the collaborative, that all burnout is local, and you have to really understand what the drivers are locally, as opposed to having some kind of national, as you said, silver bullet.
And sometimes doing an assessment is also very important and could be very useful in getting a real handle on what those needs are within an organization.
So Pam, a lot of the comments and questions on the chat focused on workforce. So we all know we have a current workforce shortage that will probably continue on into the aging of the baby boomers. What do you think are the solutions to bring more people into the workforce?
Thanks, Daryl. The plan really calls for multi-pronged approach. Not only do we need to create pathways that allow individuals to enter healthcare jobs and move along the professional trajectories, but also we know that the other part of everything we're talking about creating work environments that are supportive and empowering and that have really demonstrated a valuing of the well-being of individuals is going to be really important, because we first and foremost need to retain the workforce that we have. We need to diversify our workforce. And I think we have to demonstrate real commitment to all of these ideas we've put on paper. So it's a combination of addressing the real nuts and bolts of access to programs, helping individuals get the funding to pursue education in the health professions, providing the support to create more faculty where they're needed, creating mechanisms to ensure, again, the diversification of our workforce and programs that support that. But at the same time, I think we need to be sure that the wake-up call is there for employers across all settings, across all areas. I saw a comment about supporting rural. We know there are different needs in urban and rural environments, different kinds of settings, public health workforce. And we need to make sure that everyone says, you know, keeping the well-being of our workforce as a key value and as a priority is important, no matter where you are and who you are. I think that's the only way we're going to restore faith in bringing a new workforce and retaining the current workforce so that we can actually meet the needs of the nation.
And Daryl, if I might add to Pam's point to that question, the other thing is just to make optimal use and support of the workforce that we have in order to retain them, and also to make their contribution as much as it can be. And so that can require both local and national efforts to maximize the use of people at what's called the top of their license. So much more flexibility about roles and teams and how people work together, and how technology can support people functioning virtually from different places and contributing their expertise to the care of a patient, no matter where that patient is. So I think we can actually use the workforce that we have a lot smarter, and at the same time take the pebbles out of their shoes so they don't get so frustrated.
Yeah, Chris, I think you're really focusing on how counterproductive some of our turf battles have been about who can do what in a care setting. We really are in a all hands on deck situation where having needless fights over what an advanced practice nurse might do versus a physician and so on really aren't serving us very well.
Right. And not respecting them very well either. And that lack of respect can just, eat away at people's well-being and add to burnout.
So Barry, a lot of us look to north of the border. A lot of us in the United States look to north of the border for better ways to approach these problems. Do you think there are significant differences between Canada and the US and how we're taking on this problem?
So thanks, Daryl. We actually studied this at our own organization and compared through the survey that we did of doctors, nurses, allied health, and pharmacy levels of burnout and overall distress in our center versus comparable centers in the United States. And you might have thought that because we're in a single payer system, things are better here. They're actually statistically worse in terms of levels of burnout and overall distress. And that's likely due to, we have some of the same situations that you do, mostly health workforce related. We do not have enough healthcare providers to take care of the patients that we serve. So I'm afraid that a single payer system, it might be the solution to some things, but it's not the solution to decreasing burnout. One thing I hope I can have the opportunity to just comment on the question that you asked, Rick. I get this a lot. How do you start? How do you start to address this problem? So I think there's two things. The first is the CEO of the organization has to come out and say, this matters, has to recognize the impact of burnout on outcomes, prolonged length of stay, hospital-related infections, in some situations, mortality, the impact on the staff themselves, with the worst possible outcome of death by suicide, which sadly we, and I know many of our colleagues on this call have had some experience with. And the third is, and this may be the lever that turns the attention of the C-suite, the impact on hospital finances. So if clinicians are burnt out, they're not as efficient. There's more turnover, there's more medical legal, and it's simply good for business to address clinician burnout. So for all three of those reasons, I think it's important for the CEO to make a clear statement. The other thing I would say is our staff were surprised when they got this survey to address burnout, because they said, I heard this uniformly, you actually recognize that this is a problem. You actually care. And it was that recognition, and that recognition was, I would say, almost half the battle of saying, yes, this is a real problem, and now we're addressing solutions to that problem.
Yeah, actually, Rick, I want to turn to you on this. I think tone at the top is really important. And that means the CEO, the board chair of the hospital and the health system. Do you feel that we're shifting the tone at the top on this issue?
Yeah, I definitely think so. As Dr. Berwick asked me, I mean, this is the #1 issue for everybody. We have constant meetings going on. We had a big meeting just yesterday of all of our system execs or our committee on systems, and this is the top of the list. So to me, I don't think it's a question of making it a priority. I think, frankly, we talk about this. The time is now to do something about it. We all talk a lot about it. We've diagnosed it. We know that there are a lot of solutions, and frankly, there's a lot of. I know some people came together and said, you got to get rid of stupid stuff. There's a lot of stupid stuff that we can get rid of in terms of certain kinds of regulations and certain kind of barriers and certain obstacles that get in the way of the folks on the front line. Just one quick thing, and I'm watching the clock here, Darryl, and I know we're going to have to go to the Surgeon General, and Barry and Pam know more about this than me. But internationally, this is an issue across the globe. We recently had a meeting with the International Hospital Federation, and everybody is facing this issue. The one thing that seems to be different in our country is the violence issue, and that one seems to be more extreme here.
Yeah. Tone at the top really matters, as you point out. The violence issue is the tone in the culture, and I think we all need to pay more attention to that. I realize we're coming up on the bottom of the hour. Let me turn it back to my colleagues at the National Academy Do we have? Yes, we do. We have both Victor and the Surgeon General, I believe.
Well, Daryl, we thank you very much for the session. We are delighted that Surgeon General can join us. In fact, he's been on the Zoom throughout the entire meeting, and we want to thank him for his leadership. He's worked as a co-chair. His team has worked closely with us on this national plan, and I'd like him to close the meeting. Vivek, over to you.
Well, thank you so much, Victor. And it's really great to be here with everyone. I really enjoyed the presentations over the last hour and a half, and they just, made me even more enthusiastic about what we're all doing together. Just to start, I do want to especially thank Victor and the team at the National Academies for just providing incredible leadership, not just on this national plan, but for several years now, building the collaborative, helping to really increase the drumbeat behind this issue and put it on the map really is an issue that we should all be concerned about. And that it took, takes sticking your neck out sometimes to do that and putting in a lot of time. And they have done that under Victor's leadership. And I'm just incredibly grateful because that has actually, provided in many ways the foundation for the work that I'll tell you about that we are doing at the Office of the Surgeon General. And I also just want to thank Tom and Daryl, who have been just fantastic co-chairs, and their leadership has just been priceless here. And of course, our steering committee and the advisory groups have, just been a key part of making today possible. I'm proud of this effort in part because when I hear like the stories that that all of us hear from our colleagues across the country, it just reminds me of the urgency of the moment. I do roundtables all the time with clinicians across the country, and it's so consistent, sadly, the stories that I hear of people who came for all of the right reasons to this work, wanting to relieve suffering, wanting to reduce pain, wanting to bring healing and joy to people's lives, and are finding themselves beaten down and burned out and unable to continue. And it is heartbreaking, but it also is a national crisis because it is a threat to the health security of this country as well. And that's the part that we need the public to understand. I think that the national plan is going to be very powerful in helping lay out specific steps that organizations and stakeholders can take to help address this crisis. I think once we build awareness, we've got to transition to action. And I think the national plan is going to give us a chance to do that. I did also want to share, as Victor alluded to, that we have from our office been working on a Surgeon General's advisory on health worker burnout. And the purpose of this, and it's actually a great complement to the national plan. Victor and I have often talked about these as 1-2 punches. The purpose of the Surgeon General advisory, which I will tell you confidentially, this is not public yet, but will come out next week. These advisories call the nation to attention to address important public health issues. And in this case, we are framing health worker burnout as an issue of national importance. The other thing that they do is to help people understand what exactly is going on that's driving these critical issues. And third, they lay out clear plan of action, for the country, a broad blueprint, if you will. But what's really critical after these advisories come out is what happens next. And that's where we're really lucky to have, to have the National Academies of Medicine, to have the national plan that's going to be coming out as a even more detailed sort of plan, if you will, of what individual stakeholders have to do. Victor mentioned a really important word at the end of his remarks at the top of this call, which was the word movement. And I want to underscore that again, because that is exactly what it will take for us to reverse this crisis that we're in and get to a place where health workers are supported, where they're treated well, where they can actually do what they came to the profession to do, which is to protect people's health and well-being. And the reason it will take a movement, because one single policy or even a group of policy changes is not sustainable unless we have public interest and public support. I think we have all at this point seen policies come and go, even though they were helpful. Because again, if there isn't public interest, then these priorities shift and change very quickly. And so that is why us engaging the broader health workforce and the broader public is going to be so important. It's why, in my mind, building a movement by changing hearts and minds is the foundation that will enable the kind of policy and programmatic change that we ultimately want to see and ultimately want to sustain. So that's why I'm excited we're thinking about this in terms of a movement. And lastly, I just want to say that, I know that having talked to many of you over the last, few years, that this work is very personal to you, and it's very personal to me too. Many of us may have experienced burnout ourselves. We might be in the midst of experiencing it right now. And we all know colleagues who are struggling with burnout. And I just want to say that personal experience that we bring to this topic, that is our superpower. Even more strong, I think, than the intellectual expertise that we may bring, because when it's personal, it makes a difference. It resonates differently with the public and with policymakers. And so I want us as much as possible to bring our stories to the forefront as we talk about this with communities, with policymakers, with the media, with whoever it might be. And as we bring more health workers into this movement, as we create the opportunity for them to speak, to share their voices, to be advocates, whether it's in their institution or in the public square regarding policy, that is how we'll ultimately build this broader movement. I'll just end by just sharing with you a note that we received in my office from a nurse who'd been in practice for perhaps 30 plus years in a large city in America. And when she began her career, she was working at a Department of Health. After that, she worked at a neonatal ICU, just providing care in some of the most difficult moments in a family's life. She ended up providing MAT at a clinic later for those who are struggling with substance use disorders. She ultimately moved to a community clinic where she was providing HIV care. She worked at a homeless shelter, caring for people who are on the street and had health needs. And during COVID, she had cared for so many people who struggled with COVID-19 and cared for their families. But the reason that she wrote to us is because she said she is leaving the profession of nursing 10 years earlier than she would have wanted to. Because after all of this, dealing with the challenges of the system, dealing with environments where she didn't feel she could provide the care that she needed to her patients, where she herself didn't often have the supports that she needed, she then entered COVID, where she had to work often without PPE, was subject to physical and verbal abuse from people who had absorbed misinformation about COVID and thought that she was in fact trying to spread misinformation about how serious the disease was. And after all of that, she just couldn't take it anymore and she left. And I've read her email just even several times today. And I thought, how wrong have things gone when we took somebody who came with the right values and the right heart, provided care to some of the most marginalized and underserved populations in our country, provided care to people at the beginning, end, and middle of life. And now she's left because she can't take it anymore. And that one person represents the kind of loss multiplied thousands and millions of times over that we're risking right now if this burnout crisis continues. This is what we have to help the broader country understand, because right now I think people don't fully get what's at stake. But more and more people are now trying to call their doctors to set up primary care appointments and are finding that their doctor has stopped practicing, or they're seeing that the hospital they're used to getting emergency care in is short-staffed because they just can't hire people and people are leaving. So this is starting to hit people, but we don't want to wait for this to become an even greater crisis for the country to spring to action. So that's why I'm excited about the work that we're all doing together, about the Surgeon General's advisory that'll come out next week, and about the national plan from the National Academies that is going to come out soon thereafter, and the public comment period. I'm actually particularly glad that it is taking place, because that's going to give the public a chance to collect and share feedback and to weigh in on this national plan. And the fact that that will come right after our advisory is issued, I think it was the perfect way for us to try to get support and engagement from the public. And then hopefully that will drive some of the public comments and engagement with the national plan. So with that, just to thank you again to all of you. Thank you, Victor, again, for being such a great leader in this movement. And we will build this movement together. That I'm confident about. And if we do, we will do a lot of good to a lot of people who are doing the right thing, which is they're out there trying to care for people who need help. So appreciate it.
Thank you, Vivek, for really someone who cares about people, cares about the frontline workers, and being such a great partner. And of course, thank Darryl and Tom Nasker, my other co-chairs, really great leader, and the entire steering committee. And thank you all for sticking with us. I know there were almost 400 people participated. We need your input. The report is posted. Please send us more comments. We're going to modify it. There you go. And then, as I June the 23rd, I believe, is the day where we will formally release it. This will, of course, next week you'll hear Surgeon General Advisory. They're highly complimentary. They really, I would say that suggesting things in a complementary way that needs to be taken. And then from that point on, we're going to take action. We're going to start a movement. We're going to talk to all the stakeholders. With Vivek's help, we're going to start making changes. So thank you very much, everyone. And really, God bless. Thank you.